Good afternoon to one and all, especially to the Dean, our honored guests here from overseas, and my fellow presenters. I'm representing the Radiological Society of South Africa, and I've been on the EXCO for the last 9 years. And I'm not actually a specialist on POPI or the Protection of Information or Personal Information Act, but I'll give it my best shot. I'm going to basically discuss POPI from a radiologist perspective, and by extension a radiographer and basically all the staff members that work in an X-ray department. And as Dr. Behrens alluded, POPI was adopted by the National Assembly in August 2013, so it's quite current, and that's the teeth that are going to be added on in terms of your study going forward on how we manage our information in a radiology practice and a radiology imaging environment. Now, the version that we're working on was amended by the Council for the National Provinces, was then presented to the National Assembly, and was then sort of ratified or accepted in August 2013. At the time, and the version that we're using, President Jacob Zuma had not signed the bill yet, but the latest news on the ground is that he has signed it. I would assume before the elections, but he has signed it. And the date of implementation is now to be forwarded to us. So we do know for certain that it won't be enforced or implemented in this year, 2014, and most likely not even in the first 6 months of 2015. And I gather that, as with PAYA, as with POPI, as with the other security acts, this will go forward and will change the environment that we work in terms of private practice as well as a government radiology department. Now, I'll punt a little bit for the private radiologists here, since I am one in private. But a lot of these acts get passed, and just how Dr. Behrens alluded, the enforcement becomes an issue, and also, the reporting also becomes an issue. And, just as an example, let's take ICD-10 codes. I'm not sure if anyone knows ICD-10 codes, but these are codes that we apply to all radiology reports. So any imaging study that we report, by law, we are forced to apply ICD-10 code, which is then used for demographic and statistic purposes. So it's been implemented for the last 4 years, and basically if we report a chest X-ray and if it has tuberculosis, we need to attach a code that says tuberculosis, in which case it would be something like A16.2. Now, that was an ability for someone to then statistically assess say tuberculosis on an anonymized basis, because we didn't need the demographics of the patient. We would just say the radiologist reported 50 x-rays, of which 25 were tuberculosis. And I think, as with all these acts, the intentions are good, but eventually they get waylaid and hijacked along the way. So the medical aids, the funders then cotton on to this to say we are forced by law to submit these ICD-10 codes. Government wants it, we need to comply. And they then use this as a stick not to pay patients' accounts. So if we do not submit an ICD-10 code, we will not get remunerated for that imaging service from the funder because we didn't submit an ICD-10 code. And the irony comes in as an example. You have to actually ask the patient his permission to be able to submit this code to the funder. And there is a ICD-10 code when the patient refuses this. So when the patient refuses the option of us providing the funder for the code, we can attach a code to say patients refuse this. But guess what happens? So the patient has a constitutional right to refuse the submission of this code. But when he accepts and exercises that right, the funders don't pay us. They say it's for the patient's account. If he refuses to submit us an ICD-10 code, he needs to pay the account. So you see, the irony is that we want these acts and how they get enforced and where they get hijacked. Then my next grievance comes in is that we always enforce this in private, because private we appear to be more compliant, and we obviously we can be in breach, and we can obviously have legal issues. But you come then to a public institution or government institution, and how many departments are providing ICD-10 codes? How many radiology departments in a government hospital are performing these ICD-10 codes for the last 4 years? In fact, not many. In none of the academic hospitals in Joburg are doing ICD-10 codes in the radiology department. And we are 4 years down the line in a private setting. So again, with POPI, I'm not sure what's going to happen and how the implementation will work out. But, it might be enforced in private and it might not actually get enforced in a government setup. That is something that I'm wary of, to accept these acts and see how they get enforced equally to one and all. So just going a bit more into the actual POPI Act, and it's a bit tedious and I have to go through it. This is from a radiologist and by extension a radiographer and also the staff in our department from their perspective. So, the Act will regulate the processing of personal information. So what do we mean by processing? What does it mean that we're processing personal information? Basically, it's relating to activities, relating to activities of the patient with regard to collection of data, receipting, recording, organization, storage, retrieval, usage of imaging, usage of reports, dissemination of these reports, erasure of these reports, all have under the banner of processing. And here we're talking of living individuals, living identifiable individuals, as well as what we call juristic individuals, so, from a legal perspective. And the personal information is both medical and non-medical. So it's demographic information such as race, gender, age, any physical disabilities, mental disabilities, contact details of the patient, medical history, any correspondence between us, the patient, and the doctor, correspondence between us and the funders. And so the POPI Act is going to impact on radiologists in private practice as well as employed in government institutions. And how it impacts on us is in a private department, and I'm including everyone. From the time the patient visits the X-ray department, the person that captures all his data, the receptionist, the data capturer, to the radiographer attending to the patient and performing the imaging, to the radiologist reporting the information. It extends further. It extends to the person billing the actual account to the funder or to the patient, to the credit controller, to the debtors clerk, to the practice manager, to the PR manager, because all along the way we are dealing with the personal information of the patient. And even the credit control, if we hand the patient over, there's implications for that. What's the arrangement with the debtors company that we are handed the patient over? And as Brenda alluded to, that medical information, there's a big issue on the table with regard to medical information under the credit side, because as you know, the Minister of Trade and Industry are busy discussing erasure of credit information of the last 4 years to clean the slate. And they think that will improve the credit worthiness of people in South Africa and stimulate the economy. And during this whole setup, came to light that the credit, there's medical information that the credit companies have. And again, you could ask now, what are they doing with the medical information? They're supposed to be having financial and credit information, but they actually have medical information. And what were they going to do with this information? That needs to be seen. So as Dr. Behrens alluded, penalties are enforced. So as with any act, you have teeth, you have to have penalties. And 10 million is a decent sum of cash. And that's the limit, and obviously the added stake there of having prison sentence or even both. And again, the patients can sue us in their personal capacity. So you can even have civil claims which are going to be then upheld by the POPI Act. The Act talks about what we say a data subject. And you ask yourself, what is a data subject? So from our perspective, from a radiologist and a radiographer perspective, the data subject is a patient. Okay, so basically it doesn't have to be the patient. It can be the referring doctors. It can be any other, the lab personnel, anyone that we deal with in trying to determine the diagnosis or performing the imaging or trying to service the patient. We come to consent, and in the POPI Act, there's a lot about consent. And, you look at the different acts, there's a lot of issues about consent. The ages have varied time to time. Adult is greater than 21 years of age. Someone at 18 years of age can give us consent, and someone at 16 years of age can give us consent in certain instances. But according to POPI, it's come down to 12. Okay, so basically, a competent adult, or what we say, a child older than 12 years of age, can give us legal consent to perform imaging, to inject contrast, and to go about the business that we're doing in terms of radiography and radiology. Now, there is a variable and there's a rider there. As you know, nothing can be inked in gold. If you get an individual that's 12 years of age or greater than 12 years of age, and on your assessment appears incompetent, appears confused, or appears he's not understanding what we're talking to him, we cannot accept that as being informed consent. So though the age might be greater than 12, it cannot be informed consent if we make that assessment that the patient is confused, or for whatever reason we decide that he's not actually understanding what needs to be done. In the same breath, the opposite variable applies, that if a child is under 12 years of age and is fully understanding and appears competent to you, then you can go ahead and that's informed consent. So that obviously needs to be assessed, but I would not just take it for granted that someone under 12 years of age is competent and we should go ahead and do the procedure. So we're covered by the law in terms of 12 years of age, and that's come down significantly. Now, in the POPI Act, there's certain specific manners or certain conditions where we can process this information. I'm not going to go to those specific conditions. It's a lot of legal ease. Our initial assessment of the Act in terms of impact to radiologists is literally 35 pages long. If I have a little bit of time, I'll come back to some of these legal statements that they've given us. But there's a few points in terms of the POPI Act, and let's go through where it impacts on radiologists. And in terms of the brief given to me, what's the impact to radiographers and people performing research? Where do we stand in terms of the POPI Act and performing research locally as well as research where data is sent overseas? So let's start with the actual access to information in terms of POPI. And there are a lot of other acts. There's an act called PIA as well. So PIA is a Public Access to Information Act. And just to give you an idea, by law from last year, anyone has the right to ask for information. Whether he deserves that information is another story, but they have the right to ask for information. They could come here and have no association with the Department of Health Sciences or the Faculty of Radiography and say, I'd like to view your disciplinary records. And you could say, argue, where does this person come from? Who is he? What is he going to do with it? Yes, we can get emotional about it, but he has the right to ask for that. And according to the PIA Act, you need to have a whole setup where there's a process where you accept his application for the right to that, and there's a costing involved. It doesn't mean that you're going to provide him the information. He can ask for that information and you can say, go jump off the cliff. It has nothing to do with you. It's confidential, and we cannot give you disciplinary records of our departmental meetings, that type of stuff. So PIA comes into play. So any patient has, according to PIA, he has access to his information. He's entitled to have full access to the information and his records that are stored or archived in a radiology department, whether it's on PACS, whether it's on our RIS, the Radiology Information System. And just to give you an idea, it's going to get more difficult for us, Brenda. We have to now integrate the RIS into what we call the HIS, the Hospital Information System. So they're saying that radiologists need to be more communicative to their patients and to their doctors. We need to integrate fully into the system. Now, we can control the access internally in the radiology department, but coming to hospital access, everyone's going to have that access in the hospital in terms of the hospital information system. All staff members, from the cleaner to the labs to any other personnel. Yes, you could argue, how do we control that access? That will come into play. But it just seems that this protection of information is going to be even more difficult going forward, where they're asking us for connectivity to wider people. So in terms of consent, I've given you that we have to have informed consent. Then there's the thing coming to the correction of information. Now, just to get off the topic there's two recent court cases that if anyone's heard of. There was an instance in Germany where there was a client having some sort of battle with a bank and his cell phone provider, and eventually they sort of gave him some information where he said something and they said, no, you're lying because we know you've did this and this. And so then it piqued his interest, and he asked them as to, how did they gather that information? And so what happened is eventually it got to court, and he then said, listen, it's my information. I'd like the data from my cell phone service provider as to what have they captured about my life for the last week. All I'm asking is for 1 week of my life. What do you know about me in that week? And he got something like 25,000 or something like 30,000 pages of data, asking for 1 week of his life from the cell phone provider. And what had happened, and then what had triggered the court case, is that when he sort of was fighting with the company, they refused to listen to him, and he said, no, this is confidential, you can't have it, blah, 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 blah. But this is his life, it's data about him. And he went to court, and he won the court case, and they just gave it to him. So someone then got a written email request to say, listen, Mr. Smith wants all his data. Whatever we got, just give it to him. He's won the court case, we've lost, just give him his data. And he just expected small volume of data until when he saw how they knew exactly where he had traveled, which restaurant he had eaten, how long he spent at so-and-so place, where he went. There was so much and so much of data that he was completely shocked. So the amount of data that's extracted, they say Big Brother is watching. The amount of data that's extracted is phenomenal. And you just need to see this court case of his data for 7 days, who he visited, what time he visited, what time he ordered a pizza at 2 o'clock in the morning, which place he ordered that pizza from, and that is coming to place. But something even more recent and pertinent, and this was literally yesterday, an individual in Europe has won a court case where he has won a court case against Google to ask them to erase historical data. So I just want to give you the context. Everything of our lives gets documented on the internet, and if you Google someone, you'll see something about them. You'll pick it up, cross-reference on Facebook, Twitter, wherever. And this individual was griping about the fact that whenever you Googled his name, the big thing that came up was some sort of bankruptcy of his business. Now, he was embarrassed about that, and when the bankruptcy of his business came up, his argument now to win the case was, listen, I was bankrupt, it's an old thing, it has no implications now, I sorted out the matter, I paid my accounts, everything's done, dusted, I'm a new person, I've got a new company, I'm now financially stable, etc., etc. I'm just giving you more points there. And his argument was, why should this data of me being bankrupt maybe 10 years ago, for an example, still be available on the internet? What relevance has it today in the 21st century? I was bankrupt, I was young, I was immature, whatever, financially, incompetent, that type of thing. He won the case. Google has been asked to erase this. So once they erase it, it literally means it's not going to exist. So this is a landmark precedent case for erasure of incorrect data or erasure of old data. So we come back to radiology, and I'll be more specific here. So the correction of information. Radiologists must correct or delete information about patients upon their request. If it is, for example, inaccurate, irrelevant, and out of date, or obtained unlawfully. I don't know how we're going to obtain this data unlawfully, but anyway. And I'm sure, as per legal acts, they use the full terminology. If the radiologist does not agree with the request, a note needs to be specified on the system, on the PECs, on the result. The patient has requested erasure, and we have not complied. We disagree on this basis. If the information was changed, and coming to Dr. Behrens, it would impact on a decision related to the patient. And just to give an example, I got a practical example of a patient who is now has a medical aid account not paid to the hospital on the basis of an ICD-10 code given by myself. So we did a chest X-ray on a patient, and I gave an ICD-10 code for bronchitis. And on a subsequent admission, the patient has become asthmatic. But at the time of the initial admission, the patient was not asthmatic. It was a workup to that. And when we gave the diagnosis of bronchitis, that was valid. His accounts have not been paid because the diagnosis of bronchitis is not covered, but the diagnosis of asthma is covered by his funder. He now has a financial implication on the basis of my ICD-10 code, a real practical example. He has now requested me to change the code. Now, I'm still debating about this. So one, there's no need for me to lie. I don't need to lie. Secondly, must I change the code so that his accounts get paid? Thirdly, do I even entertain his request? This is a real practical example now in the practice. So if the information was changed, it would impact on a decision relating to the patient. Example, a funding decision by a medical scheme. The relevant party, the medical scheme, also has to be informed of the change. If the accuracy of the information is disputed, then we need to restrict the processing of that information. And again, you're going to ask me, how do we know it's inaccurate? I'm not sure how that's going to happen. And coming to trials and research and data capturing. So the specific heading there again is cross-border clinical trials and trans-border flow of information. The Act prescribes a basis upon which personal information may be transferred to other countries. Prior authorization from the information regulator. Now the information regulator is a body that's going to be set up that's going to then implement and enforce the POPI Act. So you need to ask for information from the regulator to transfer health information and information especially of children to other countries. And if the cross-border clinical trials involve the transfer of data to what they regard as countries that don't have adequate levels of control and adequate levels of protection of personal information, you need to make an application to the information regulator to allow this again. You cannot just give this data across to someone. There's a few other points that they go into coming to directories. They say, coming to us as radiologists, radiologists are entitled to verify, confirm, or refuse the inclusion of their personal information in directories. Now, I'm not sure how that comes about into the Act and what we're trying to achieve. They then come to an important concept of PACS, specific heading with PACS. So this whole POPI Act, I'm slanting it towards what the impact is to us. So disclosure of information and the PACS system. Disclosure of information about patients to any third party should comply with the requirements of PIA. So you need to be PIA compliant in terms of that access to that information. We need to have written informed consent from the patient to archive his data on the PACS, to allow other clinicians to access the PACS, to allow any other person to access the PACS. And just to give you an idea, PACS managers are not necessarily medical people. They're not. It would be nice to have a medical person as a PACS manager, but the person dealing with the PACS is not necessarily not a radiographer or a radiologist. It's usually an IT individual who is not bound by the Health Professionals Act, as per a lot of our administrative staff. But we do work in a closed environment, and everyone does have passwords. And I'll come back to that passwords. So care should be taken by radiologists when allowing third-party access to the PACS systems, and also sending the information to the PACS, and referring system to referring doctors and other healthcare practitioners. We need to comply with the PIA Act. We need to comply with the POPI Act. We need to set up what they call an information officer. So in terms of the POPI Act, the head of a radiology department needs to have what we call the information officer, and he would then be in charge of making sure that POPI is enforced and there's strict security and access to the information and how it's controlled and how it's disseminated. They go to what are the information sources. So radiologists would typically collect information directly from patients, which they refer to as data subjects, but also from referring doctors and potentially also from healthcare practitioners in other hospitals. Now, where possible, consent for the collection of this data needs to be obtained from the patient. And the collection of personal information from patients from referring doctors do not prejudice the legitimate rights of the patient. When the patient's in hospital, we need the information from doctors, nurses, anyone that's been dealing. We need the blood results of the patient. Otherwise, we cannot service the patient. We cannot attend to the patient. So the Act covers that in the nature we're trying to help the patient, and that's why there's a free flow of information. But they also go to a point where what happens if the patient's incompetent or non-compos mentis, if he's having status epilepticus or if he cannot give you that information, they allow you to then legitimately get that information from the other sources. So if the patient can't give us that information, we cannot get informed consent from the patient if he's in status epilepticus. We need to just work within the Act and within the moral and the legal background that we have to be able to gather that information from his wife, from his siblings, from his children, from his referring doctor, because we cannot get the consent from the patient also at the time. There's an interesting point coming to the outsourcing of information management and the debt collection. And that comes, again, a little bit to the administrative staff in the practice, and they might be fully employed by the practice or they might be outsourced. They say, should a radiology practice, for example, outsource the processing, distribution, and collection of accounts? Example, to a clearinghouse or debt collector. And we do that. Once we reach a certain stage, we have to hand over the patients to a debt collector. Such an entity would be regarded as an operator under the POPI Act. We need to have a legally binding agreement to ensure confidentiality of all the data that we're giving over to the debt collector as well. Now, obviously, we're not going to give medical data to the debt collector, but here we're talking of the personal demographic data to the debt collector. That also needs to be bound and is regulated by POPI. And interesting other points, they refer to any discussion with the data. So when we're having multidisciplinary patient discussions, and we normally do this, we have a meeting with a pulmonologist, we have a meeting with the GIT guys in terms of presenting the case and then presenting the findings of that particular case and discussing the way forward, discussing future imaging, biopsies, etc. We need to get, again, consent from the patient. We cannot just discuss his history in a proper clinical discussion. So POPI again governs that when we openly discussing with multiple other doctors that are not necessarily involved in that patient. So the patient's admitted and he's been treated by a particular physician. We then discuss his history or his diagnosis with a non-patient physician, like a hematologist. So we tell the hematologist something about the patient, whatever in the discussion. The hematologist is not actually looking after the patient. He doesn't even have consent in terms of the patient because that patient is not his. So it governs that as well, where we got to be mindful of the patient's rights. And it goes on to marketing as well as reminders. Just to give an example, so patients with mammograms, we often have patients with mammograms, and it's the one instance where there's repeat visits. You have a chest x-ray today, we don't tell you come back in a year's time for your chest x-ray. But you have a mammogram today, we tell you, listen, you need to come back to us in a year's time, should you remain healthy, for the repeat mammogram. And POPI Act again comes into play there. It tells us that we can't just send patient reminders just willy-nilly to them to tell them to come back in a year's time, even though that's to their benefit. That at any point in time, we got to ask the patient to have an option of opt-out. You get all these spam emails, or you get all these marketing emails, and they tell you opt-out, please tick. So you got to even give that option to the patient to say, listen, you on our SMS list for mammogram reminders every year, and you have the option to take yourself off the list, much to their not dissatisfaction, but it could be to their detriment, because if they forget to come for a mammogram and lo and behold a cancer develops, there could be a legal and moral ethical issue there. So these reminders are even governed by POPI. And they also talk about the fact that if we, and this applies to us at the moment, so we have a marketing firm at the moment that wants to do some sort of mammogram marketing. And while reading this, it tells us that yes, we can market within reason with the ethical boundaries with the Health Professionals Council, but be aware that that patient is not a patient yet. You are marketing for people that are not patients yet to come for a mammogram on the basis of whatever. And when they do come for a mammogram, they then become a patient. So there's even a POPI issue that this person that we're marketing to is not yet a patient and now becomes a patient when they do present for the mammogram. So it gets all intricate, and it's amazing where some of these things that have come about, and I've been reading this stuff. And a little bit on profiling, quality, record keeping, quite interesting on record keeping. Coming to record keeping, they say the Health Professionals Council. So here the POPI then takes a bit of the chunk of the Health Professionals Council as to how we record and keep and archive patients' data. And remember previously we had the story that we needed to keep patient reports for 5 years. And this was just the written reports. And then we then came to PACS, and we now need to archive patients' imaging data. And there was something passed last year about us keeping it for a period of 6 years on our PACS. And you know what? Reality bites. It does happen. And as Dr. Behrens alluded, our systems have crashed 2 times. And the once when it crashed, we lost all the PACS data. And we managed to only retrieve 70% of the data. We had a backup, and even the backup didn't help us. So it's like this, by law, hospitals in South Africa are meant to have a generator because of our power outages. So by law, you're meant to have a generator. But by law, you're meant to have a generator to cover the generator as well. So we have a PACS, we have a backup PACS, and then what? So we lost 40%, 30% of our data we lost. And that was just pure hardware crash. So coming to profiling, it says profiling of radiologists and radiology practices. Now, this is a big area at the moment. A lot of our accounts get profiled. How we bill and how much we bill is profiled by these companies that are not related to the patient. And so they want to know on that patient, what did we bill and what was the code and is it right or is it wrong? So a lot of profiling happens. And the POPI allows for profiling within reason. It allows for radiology practices for administrative purposes and for financial reasons to be profiled. And you could argue that that's again a breach of confidentiality, because when they profile, they need all that data. Radiologists must ensure that the personal information of patients is complete, accurate, and updated. And that's simple. Coming to the records again, we need to keep the records of any child up to 21 years of age. Any incompetent or non-compos mentis person for his whole duration of his life. We need to keep the records, both the written reports as well as the PACS, as well as the imaging data. We can keep records older than 21 years of age. It just depends, but I don't think that's going to happen because the PACS are evolving, IT is evolving. Every 2 years it's sort of changed. We have to integrate, we have to change, and I don't know how long we're going to be able to keep this data going forward. So keeping something for life sounds really unreasonable, as much as it's against the POPI recommendations. And again, just ending on the security safeguards, what Dr. Behrens have also alluded to from the POPI notes from MPS, is that radiologists must ensure that the practices have the necessary safeguards in place and that these are continually reviewed and enhanced in response to risks and deficiencies that we find. The security safeguards do not only refer to system security, but also processes within the practice and access to information. The radiologist must report on any unauthorized access. This is the difficulty. They must report on any unauthorized access of personal information of data subjects to the information regulator. How are we going to report it if we don't even know that there's been unauthorized access? And obviously the PACS, we have all the staff members, and maybe giving you a practical example in our department, everyone has passwords. And we expect them to use their passwords to gain access to the patient, the radiology information system, as well as the PACS. Non-administrative staff know not much about the PACS. They really don't know how to access on the PACS and what goes on. All our PACS in the country are overseas based. What I mean is that there isn't a South African PACS. So when you get a PACS that's Philips G PACS, you get an automatic hyper disclaimer on the first page. As you open up the PACS, the hyper page comes up first. So again, you might argue it becomes second nature. You look at hyper, you just tick it and you carry and you don't think about it. All our faxes that get transmitted, we have a confidential page that tells you there to try and cover us as a rider that we have sent this fax. It's personal medical information. If you are not the authorized representative for this fax, please inform us, please delete the data, that it's faxed to a specific person. So all our faxes go out like that with a cover sheet in terms of that. But again, faxes are they're open. There's no security on the fax. In terms of PACS access, all the referring clinicians have specific passwords. So, we're assuming that it's just the doctor accessing the PACS. But coming to this whole setup where we're going to integrate in hospitals, doctors are not there all the time, and say an emergency x-ray gets done, it gets sent on the PACS, the nurse has to access that. They have to access that x-ray, then convey to the doctor. So the communication and this interlink with the hospital information system is going to open up a whole nother scenario for this confidentiality and trying to enforce poppies. It's not going to be easy, but in essence, we're doing that already. We haven't really had security breaches. I've had an instance where someone hacked into the Wi-Fi system in the department and then came to tell us. And at least they told us and we picked up that breach in terms of that. So these things are pertinent, they're relevant, and they are going to impact on a radiology practice because no one's mentioned costing. And to give you an idea, if I change passwords every month, it's going to cost us 2,000 to 5,000 rands or whatever for 100 people because the vendors have to come out. You can't change the passwords yourself. So we have a staff of 114. And can you imagine that short of a few porters and that everyone has a password? And if we change in passwords every month, it becomes an issue. What I do like is the biometrics. And maybe that's a way forward for us to attach a biometrics onto the PAC system and onto our information systems. And maybe that's a way where we can then control this information. So I thank you for your attention. I thank you to the Faculty of Health Sciences and the department for allowing me the opportunity to present on a bit of POPI and representing the Radiological Society of South Africa. I'm not a POPI expert. I've had to wing this in terms of the data. There's a lot of data and it's all in legal jargon. It's open to interpretation. It's very variable, so you can argue otherwise as well. But hopefully you've got the gist of my talk. Thank you.